Good afternoon. Sorry about the technical difficulties. I'm Jeff Mitchell.
And I'm Gina Joseph.
And this is Hip Check, navigating canine hip dysplasia. So today we're just going to be going through an overview of canine hip dysplasia with kind of a surgery and a rehab kind of perspective. Before we get started, I want to thank Nordic Naturals and Hills for sponsoring the CE event. I believe Nordic Naturals is actually going to email you all with a potential discount for some of the products. And we will have a Q&A session at the end, so feel free to kind of submit those. If anyone's having any difficulties with video or audio or anything like that, feel free to message Izzy, who will be kind of on the chat here, and she can try and sort that out for you. Okay, there we go. So to start, we're just going to briefly overview just some changes going on at Animal Surgical Orthopedic Center in terms of the referral process. So I guess in the past, classically, what we've seen is that there's been the option to refer to the surgery department or to the rehab department. But that did kind of leave a little bit of a gap there for some of those cases that maybe needed a little bit more information, like maybe a diagnosis was known, but we need a little more information on really deciding if it's going to be surgical or a rehab case, or maybe just need a little more workup need to be done to get a diagnosis to figure out where it needs to go. So with that in mind, we did kind of create another department. So this is called the Orthopedic Medicine Department or Ortho Med Department. So this is going to be kind of the diagnostic arm for ASOC, where they will be doing some of the workups for some of these more difficult cases, but also they'll serve as kind of also a non-surgical treatment center for some of these more acute to subacute lameness cases. So maybe some more of those soft tissue type injuries where it's not quite a rehab case, but not quite a surgical case. For the overall, like how that affects you, really the referral process should not really be affected that much. This is mainly structured internally, so the way that our front desk will kind of look through records, discuss cases with your clients, it'll essentially help us decide which department it'd be best at. As you get to kind of know the system, if you have some ideas on which department maybe sounds the best, you can definitely lay the groundwork with your clients and kind of give them an idea of where you think they'd be best served. But we're just trying to streamline the process for you all, and hopefully, help your clients navigate the best way to kind of use us. In terms of whichever department they get sent to, whether it's surgery, ortho med, or rehab, I guess one important thing to note is that we're all in the same building. We're doctors' offices directly across from each other, so we'll still consult about cases. So we'll still take a team approach on these kind of situations, whichever department they go to. So I guess with that in mind, we have Ortho Med and our head for Ortho Med here, Dr. Gina Joseph. So I'll let her introduce herself a little bit more.
Hi, thank you so much, everyone who's logging in. Just a little bit about myself. I'm a Southern California native. I grew up in Ventura. For those of you who are not familiar with Southern California, it's kind of halfway between Santa Barbara and LA and right on the beach.
Great fish tacos.
Yes, excellent fish tacos. And from there, did my undergraduate training at Cal Poly San Luis Obispo, and went to vet school actually at Midwestern University. And then from there always knew I wanted to specialize, thought I wanted to be a surgeon because I always really loved orthopedics. And then life made a couple of different turns. I did a rotating internship and a surgical internship at two different private practices, but ended up really finding my love in sports medicine and rehab. And so went to Colorado State University and joined their orthopedic medicine mobility department as one of their residents and finished my residency there. I have two lovely fur children, Dodger, my dog, named after the baseball team that I adore, and Bogey, my cat, who are both very incredibly spoiled. Otherwise, like I said, huge baseball fan, huge music fan. So I saw Elton John at Dodger Stadium, so best of both worlds. And then otherwise you can find me curled up with a good book. But enough about me. What do I actually do? So OrthoMed is this new sort of emerging branch, I think, of orthopedics. And like Jeff mentioned, the cases that we handle the best are those really frustrating undiagnosed forelimb lamenesses that we just really want to figure out why these dogs are lame. Any of those nebulous soft tissue sprain or strain injuries, your older patients with elbow dysplasia or just even generalized osteoarthritis that maybe aren't the best surgical candidates. And then of course our non-surgical fracture cases. These are all things that absolutely fall into our wheelhouse. And I think the most important part of my job is doing that really good orthopedic examination and trying to really localize where the pain comes from. From there, I can analyze their gait, both either just subjectively watching them walk and move through their environment, and even in some cases using, force plates, pressure mats, things like that to kind of evaluate and track lamenesses. Of course, we can do x-rays. Musculoskeletal ultrasound is growing as a huge diagnostic option so that we don't have to jump to something like an MRI for some of our soft tissue injuries. And then CT scanning, doing joint taps, and of course bone biopsies. And then from there, what can we do with all of that great information? So joint injections for arthritic and painful joints, using things like steroids, PRP, stem cells if needed, and even playing around with synovitin, the once yearly injection. Other things we can do are things like shockwave therapy, good for soft tissue injuries and osteoarthritis. Of course, working with our amazing rehab team to build a staged rehab plan to get your dogs back to their comfort, and things like orthotic devices and other assistive braces, even prosthetics. Again, non-surgical fracture management, give me all of your casts and splints and bandages. And then again, what I think the most important part of my job is to be and kind of help direct your clients to the surgeons like Jeff and the rest of the team when they need surgery, or over to my wonderful rehab team, either post-operatively, immediately, or post-operatively months or even years down the line, or just if, again, surgery is not an option. So I like to kind of be the link between all of these different departments. So from there, while you guys are all here, to talk about hip dysplasia. So sort of how we'll go through this discussion, we'll talk about what is hip dysplasia, how do we diagnose it, how do we diagnose it early, how do we medically manage these guys, so initial strategies that you can implement in your practices, as well as maybe more advanced things that you can refer to us, the surgical options, and then post-op management. So from there, I will hand it back off to Jeff.
Thank you. So for kind of hip dysplasia in this discussion of just how to diagnose it, I guess I mainly concentrated on more the juvenile hip dysplasia. I guess when it comes to adult hip dysplasia, a lot of people can probably look at a set of x-rays and you're going to see some arthritis and all that kind of stuff. It can be a little bit more obvious. I do find like juvenile hip dysplasia can be a little bit trickier sometimes. So I'll kind of concentrate on that. So for the signalment, I mean, this can happen in any breed, most often in the larger giant breeds. This is going to be something more so maybe faster growing puppies and dogs that have or maybe fed excessive calories or excessive calcium while they're growing can also be at an increased risk for this. So certainly diet is important for these puppies. For clinical signs, I mean, this can be really variable. You can see a unilateral, maybe just offloading of the leg or shifting weights, sometimes more bilateral lamenesses or just stiffness when getting up or getting around. Sometimes this stilted gait, which you'll sometimes see in more severe cases of hip dysplasia. Like this is something where if you look at the picture, the Roddy here is both his hocks and stifles are extended. It's really trying to offload pressure to the front limbs. The other thing you can see in that set of pictures is that Roddy's legs are essentially kind of pushed out a little bit. It's essentially their way of trying to keep their hips a little bit more reduced. And that's in comparison to more like geriatric hip dysplasia, where you might expect more of a narrow base stance, as they're trying to keep their feet together, pushing their hips away from their pelvis because it's, just a little bit more comfortable that way. And then there's classic things like bunny hopping and exercise intolerance and stuff like that too to look for. But the key thing, I guess, about hip dysplasia as dogs are developing is that hip conformation is certainly a big part of it. But joint laxity also plays a huge part of this too. And so, when it comes to evaluating joint laxity, there are some physical exam things we'll talk about. But even from the standard radiographs you take, they can sometimes miss that joint laxity. And so unless you are really screening for hip laxity and hip conformation, you maybe are going to miss some cases. So for physical exam wise, it can be difficult for sure in juvenile hip dysplasia because the problems are like some of these dogs can be uncomfortable with your physical exam or extension of the hip, abduction of the hip, stuff like that. But actually with early stages, like there may be some reasonable cartilage in the joint still, so they're not overly painful. So maybe in more mild, moderate cases, you may be missing that just on your physical exam. Ortolani sign can be extremely helpful. If you're familiar with it or if you do this on a regular basis, this can be a big tool for you. But generally what I would recommend is it's probably better when patients are sedated. If you have the right kind of patient that's relaxed enough, you probably could try and get Ortolani with them while they're awake. But it can be tricky. But essentially you're creating a weight-bearing force through the femur. And then as you do that, that essentially subluxates the hip joint. And then as you abduct the hip, it will reduce the hip and you should feel or hear a kind of a thump, and that'd be a positive Ortolani sign. It's important to note that it's not 100% sensitive or specific for a dog that's going to develop arthritis long-term. It basically just tells you that there is hip laxity, but in general, I guess puppies will have a little bit more laxity to their joints as well. Did we just get signed out? All right. Moving on. So I guess if you have the right case, maybe the right breed, some hip discomfort, any signs of lameness in a young dog, especially if you're getting a positive Ortolani sign, probably would be a good idea to follow up with just some hip radiographs. But when it comes to evaluating the hips in these juvenile dogs, not all hip radiograph techniques are kind of created equal. So we'll kind of go through that too. But just basics for radiographic technique here, like proper positioning is so essential when looking at the hips. Standardized views is really going to improve your interpretation. And so typically whenever we're doing these hip radiographs here, I'm always kind of harping on our technicians that we need to get them as straight as possible to really be able to evaluate the hips well. And along with that, if sedated sometimes gives you a better shot at getting good positioning on these hips too. It just makes it a little bit easier to get that position right if you don't have a dog kind of struggling with you. It definitely improves your options for palpation while they're sedated. While they're sedated, you're probably much more likely to get that Ortolani sign if it's something that you can actually elicit. It's also a good opportunity to feel the knees, make sure that there's no signs of cranial drawer or any kind of patella luxations, stuff like that. It also, some other benefits, decreased radiation exposure for your staff. They're not having to take as many views. They can get the right views and fewer shots. And then probably just less stress on our patients too. So it's a very helpful tool. So for this slide here, I just wanted to take you through an example. So I actually purposely cropped out the ilial wings here. I just mainly wanted to concentrate on the kind of femoral head coverage, and then also looking at the obturator foramen. So this is the tool I tend to use the most when it comes to trying to evaluate the hips and decide if they're straight or not. So I guess if we look at this image here, if you just take this image at face value, and these little red lines are going to represent the dorsal acetabular rim for both sides. if you look at this, you would say that, yeah, the left hip has some dysplasia to it. The right hip is kind of borderline, but really not too bad. However, if you actually interpret these raps and look at, how is the positioning and all that, you would see that the obturator foramens are not equal in size, which means the pelvis is not straight. So if we kind of outline the obturators, the right obturator foramen is definitely bigger than the left. So I always think of that as like whichever obturator foramen is bigger is also up. So the right hip in this example is up from the table compared to the left. So that is going to falsely make the right hip look better in the x-ray compared to the left hip, but just going to look more shallow. So my correction, if I catch this at the time when someone's taking some radiographs, I'm going to have them push the right hip down. Or if, like you, sometimes I'm not there for the radiographs. If I'm catching this when I'm having my lunch at 6 at night or something like that, I'll just kind of mentally make that change or shift in my head to hopefully make the better read on what those hips are doing. So, I mean, this is something I do kind of every day. It really is very helpful to be able to identify whether the pelvis is straight or not. So in terms of kind of screening tools, probably everyone's heard of OFA films. It's, the most common screening kind of tool out there. It only involves a one hip extended VD view. It's fairly subjective, I would say. It's, they have grading scores from excellent to severe. It's mainly based on conformation of the hips, like femoral head coverage and in presence of arthritis. So this particular tool is not exactly the best for identifying juvenile hip dysplasia, just because it's not really overly accurate until dogs are over two years of age, which is part of the reason why OFA films are not allowed or are registered until 2 years of age, because they're just not going to be overly accurate. And the main reason it becomes more accurate after 2 years is because you start seeing more and more of that arthritic changes. So it kind of increases your sensitivity. So, if you have a young dog, definitely less than 1 year of age, you may be looking at probably getting a lot of false negatives. One of the reasons why that could happen is, well, first, you're not going to see a whole lot of arthritis at first when they're that young. The other issue or thought is that when you're extending the hips like that and pulling back the femurs, it is going to kind of create this tension or wind up on the joint capsule and the soft tissues around the hip, which could potentially actually pull the femoral heads into the acetabulum further. And that's going to give you this kind of false impression that there's better femoral head coverage than maybe there naturally is. So in terms of what I would say, and probably a lot of people would say is a better option, now it's definitely a bit more of a pain, but it is definitely the best screening tool, most evidence-based screening tool that we have for hip dysplasia. It's actually accurate at 16 weeks or greater. And honestly, it's probably accurate before that time, but that 16 weeks is when you can actually register these patients to be pen hip certified. So the images here, there's actually 3 images that you're supposed to take for these pen hip films. There has to be an extended VD, a compression VD, and then a distraction VD. To get these films and get them all standardized, there is a certification and training required. It is free and online. It's open to specialists or to general practitioners. And there is, I think, a cost for just getting the kind of special distraction device, which is, right here. So here's the example of the distraction device. Here's this example of the positioning that's done. So it's actually pretty easy to do, but it gives you a lot of good information. Here's on the right side is an example of some of the measurements being done to basically calculate the distraction index, which is going to give basically a number, a very objective kind of measurement on how lax are those hips. And it's much better at predicting whether or not a young dog is going to develop hip dysplasia or hip arthritis or not. So I guess if you have the kind of clients that are motivated enough, maybe if you're working with breeders and they really want to be extra responsible with their their genetics there, not pass on any hip issues, this would be a great tool to start implementing. We'll come back to this a little bit when we're talking about some of the prophylactic surgical options. But at least for now, let's just say, we diagnosed hip dysplasia. What's the next step? typically for most, forms of hip dysplasia, the first step should usually be medical management prior to really going the surgical route. Surgery is probably more reserved for the more severe cases of hip dysplasia and all that kind of stuff. As much as we like to do surgery, they're probably better served with initial round of medical management. So I'll turn it back over to Dr. Joseph.
Yeah, and as someone who recently went through the Pen Hip certification process, it's a great team to work with. I think definitely worth the time, especially since it is free, at least for the actual certification. I use it a lot as my hip screening tool in dogs. But for medical management, I always think of these 5 pillars of medical management. A lot of these things are things that you can implement in your practice to get your patients and your clients going before necessarily coming in to see someone like me or like Jeff. And those 5 pillars are weight management, that's critical, pain medications, of course, activity modification, physical therapy, and joint health supplements. And we'll go into each of these in a little bit more detail. So weight management, I'm sure everyone is aware of the studies out there now that looking at cohorts of Labrador retrievers, showing that not only do they have improved mobility, but less severe OA, and usually end up living longer. That Labrador study showed that diet restriction of about 25% of their, counterparts showed definitely less severe osteoarthritis in the hip and shoulders. Those dogs ended up weighing anywhere from 80 to 100% of kind of their targeted weight. So definitely not underfeeding them by any means. As I'm sure you guys all know, each BCS point above ideal using that Purina body condition score scale ends up being about 10 to 15% of excess body weight. And I use that all the time. Pretty much every one of my patients that sees me goes home with some sort of diet plan, taking those things into account. But honestly, even studies have shown that about 6 to 9% body weight loss has shown a significant improvement in leanness in obese dogs. And that's also been my clinical experience. If you have, our little corgis who love to pack on the pounds, they're 20, 25, sometimes even 30+% overweight, even just getting them down a single point where, they've lost 10%, going from an 8 to a 7 or a 7 to a 6 makes a huge difference in their comfort and mobility. My general rule of thumb for what is healthy weight loss and how fast should they be losing weight is for about 1 to 2% of a decrease in their body weight per week. I've actually made an Excel spreadsheet that my techs can pop in their current weight in pounds, how much overweight they are, and it generates a table of about how much their weight should be each week, which I think is really helpful given to owners. It's pretty easy to do, especially if you're Excel savvy, but I think it's a really helpful resource we can provide to owners for making sure that we're on track. So when you see this dog back in, 4 or 8 weeks, are we hitting those benchmarks? Because if we're not, maybe those are the points where we need to modify things or, potentially get nutrition specialists involved, or even consider switching to prescription weight loss diets like metabolic immobility, things like that. And then obviously reassessment by a veterinarian is crucial. I a lot of times will encourage owners to, especially with my large breed dogs, just bring their dog by the clinic and use our scale. Come in once a week, come in every other week, just for a weigh-in. Plus, I think it also helps patients not feel so anxious at the vet because they get extra cuddles, and it's a super easy visit. This is a thing that I push kind of more than almost any of the other things with my patients, because one, it's no cost to the owners, and two, it can make such a significant difference in not only, again, their mobility and their orthopedic health, but their overall health. So from there, our pain medications, pretty much my go-to for any of my orthopedic patients, whether it's dogs suffering from hip dysplasia or any of my other orthopedic conditions, I usually start them on an NSAID. They've been shown to be just the best thing we have so far to combat orthopedic pain. Osteoarthritis in and of itself is primarily an inflammatory disease process. So controlling that inflammatory cycle should help disrupt that pain signaling. Obviously, lots of different options for use in osteoarthritis. In my personal experience, I reach for carprofen a lot, but I have had dogs that don't tolerate carprofen and maybe respond a little bit better to meloxicam or Previcox. So I will sometimes switch it up if I'm not getting quite the expected pain response or improvement in pain that I'd like. Of course, you can always reach for steroids. I encourage those more in the cases where we have a really severe inflammatory response, and especially when we're not looking at surgery. But again, more often than not, I'm reaching for my anti-inflammatories rather than my steroids. A lot of people also use Galliprant due to it being more specific than our traditional COX-2 specific. It for sure is an option and one I'll reach for in patients that maybe have some underlying renal disease or liver disease. And I've had dogs improve on it, but generally when I can, I try and reach for those COX-2 specific anti-inflammatories. I wanted to touch a little bit on cats just because we can see hip dysplasia in cats. And I think we've all been in school and seen the black box warning on meloxicam, but we're seeing more and more positive research showing that at low doses, it can be helpful and even safe in cats with low iris stage CKD. So other medication options, because sometimes anti-inflammatories just aren't enough. Usually from there, I'll reach for something like gabapentin, or more and more I've been using pregabalin since it's come off of patent and become a little bit more less costly and more practical for our patient population. Obviously, it's a GABA analog. There is research that suggests the bioavailability of pregabalin is better than that of gabapentin. Have we shown that that necessarily equates to better pain management? Unclear. In my personal experience, I've found that dogs who were maybe not super responsive to gabapentin and then I switched them to pregabalin did tend to do better, at least reported by owners. Is that just because gabapentin ideally is given 3 times a day and pregabalin can be given twice a day? Maybe. I'm not totally sure, but I think the important thing to note is that we don't have a lot of controlled clinical trials demonstrating the analgesic efficacy of gabapentin or pregabalin. It is helpful, obviously, in cats, not only for pre-visit sedation and, making the vet visits less stressful, but just also helping with our geriatric cats. From there, a lot of times I'll reach for something like amantadine, or in my dogs that are really chronically lame and uncomfortable from their hips. Even the young guys where they have a lot of that laxity and discomfort from that hip joint kind of popping in and out of place, the secondary muscle soreness that I'll see. Sometimes it gets to the point where I need to reach for something like amantadine to help with that centralization and chronic pain. It has been shown to be effective in combination with meloxicam in dogs that have osteoarthritis, but that was refractory to just a single NSAID treatment. And then obviously we're starting to break new ground with these monoclonal anti-nerve growth factor antibody medications. I know Librela is coming soon. We're all anxiously awaiting its availability, and then even Silencia in cats. So again, probably not something I would reach for as an initial therapy, more so when we're again deciding to medically manage these guys long term, but a great tool I think to keep in our back pocket. So from there, looking at kind of activity modification and physical therapy, I lump these two things together a lot. I have a cute video of one of my favorite patients doing rehab to show that kitties can do rehab too, and they can do it really well. And also a lot of these exercises, as we'll kind of touch on a little bit later, are things that I'll use for dogs and cats with hip dysplasia. So my goal with exercise, therapeutic exercise, rehabilitation, activity modification is just to maintain muscle mass and joint mobility as much as possible. So different things I can do from a rehab perspective are, of course, our superficial thermal modalities, so cooling and warm packing. It can help provide pain relief, and obviously either vasodilate or vasoconstrict as needed. Generally, after an acute injury, I'll start with cold and do that for 2 to 3 days, and then transition to warm, or if I have primarily muscle soreness. Again, these young guys, when they're dealing with a lot of laxity, can have a lot of compensatory muscle soreness. Something super easy that you can recommend owners do at home that can actually provide some pain relief as well, especially in your owners who are maybe a little bit resistant to medications. Other things like muscle massage and joint mobilization can help break up adhesions from chronic inflammation and provide pain relief. Like again, we saw in our video, low impact and controlled therapeutic exercise. We can do things like land treadmill, and underwater treadmill is actually one of the best things that I can do for my hip dogs, and they respond really well to it. Obviously, you guys don't all have underwater treadmills. So even just getting your owners to take their dogs on regular leash walks, I think if we can do that, you know, controlled leash walks for our dogs multiple times a day, you know, length kind of depending on the dog and their endurance and stamina, I think that can go a really long way of maintaining comfort and mobility. Other modalities that you may have heard of or may see in some of our records that we'll use are things like therapeutic ultrasound, laser TENS, which is transcutaneous electrical nerve stimulation, HEMF, pulse electromagnetic field. Those are all different kind of specialized modalities we can use in hospital to help provide some pain relief in a few different ways. And of course, acupuncture, you know, we're getting more and more evidence for the pain management aspect that we can get release of endogenous opioids, the idea of gate control theory, and just improve circulation to those areas. So all of these are tools in our toolbox that we can use. But like I said, a lot of these things are things you can work on with your clients or have your clients do at home. So from there, joint supplements. I'm sure we've all had clients come in asking about X, Y, and Z supplements. There's so many out there, and it can be really tough and confusing to kind of navigate what to recommend, what not to recommend. By and far, I find the joint supplement with the best evidence behind it are our omega-3 fatty acids, specifically EPA and DHA. You know, we've shown through studies that supplementation can help improve weight bearing and can decrease the need for anti-inflammatories due to their natural anti-inflammatory properties. And the nice thing is a lot of times, especially in our great joint diets, again, like metabolic and mobility, they have therapeutic levels in them. So of course, you can, that's all if you're like me and you don't want to deal with adding a bunch of stuff to your dog's food. Just buying food with it already in makes life easier. But of course, you can use over-the-counter supplementation, you know, I tend to like the liquids from companies like Nordic Naturals, where you can just add it to the food. It tends to be a lot easier for owners actually versus the capsules, because I think the important thing to know is that the recommended doses that you'll see are usually for some of your skin, your heart doses, and the orthopedic doses are actually generally twice as much as that. So I find a lot of my dogs who are coming in on some kind of omega-3, when I actually do the calculations, are not quite receiving enough. And so the liquids I find tend to have just much higher levels of EPA and DHA in them, and so you don't have to give quite as much. From there, obviously, Adequan, again, a really great, as I explain it to owners, it kind of toes the line between being a medication and a supplement, since it is an injectable, but it is one of the few disease modifying agents that we have. It's been shown to inactivate the enzymes that break down cartilage in these degenerative joints like hip dysplasia. And that's been shown at that loading dose of twice a week for 4 weeks. They do also talk a little bit about anti-inflammatory and pain relieving effects. We don't really have the studies to say for certain that happens, but I do, again, anecdotally, I have clients that absolutely say they notice when their dog doesn't receive their monthly injection, they notice a difference. Again, I tend to find that more in my chronic dogs. For these younger dogs that we're, initially talking about, initially diagnosing, I really try and focus more on that loading dose for more of the preventative effect. So a lot of times I'll actually recommend owners do that loading dose for, the 4 weeks, and then repeat it every 3 to 6 months. We can modify things. I think it also makes it less overwhelming for owners as well when I have their 8-month-old bouncing Labrador and I say this injection can really help, but you have to do it once a month for the rest of the dog's life. That's kind of a lot to for them to digest. So saying, okay, we can do this loading dose that's been shown to help delay osteoarthritis, and just repeat it 2 to 3 times a year. I wanted to include some other things. Undenatured type 2 collagen is something that's been showing some promising research, something super easy to get over the counter, that has been shown to improve mobility scores and in arthritic dogs. That can be helpful. Again, I think we still have a ways to go. I think it's important to note that there is a study out there that shows possible decreased efficacy when it's given in conjunction with glucosamine chondroitin. Can't say that for certain, but something I always warn owners. And then, of course, glucosamine chondroitin. The hope is to stimulate synthesis of synovial fluid, inhibit degradation, and just improve healing in these arthritic joints or degenerative joints. I think there's pretty mixed evidence for benefit in literature. My personal stance is if I have a client that comes in, they're already on it, I say that's fine. But generally, if I have a client come in, they're not on any sort of joint supplements, it's not one that I'll necessarily push. Again, I think I take the stance of it might help, it's not going to hurt, but I think I have evidence for some of these other things, again, Adequan, omega-3s, that I would focus on more. And then from there, like I said, those 5 pillars can be your jumping off point once you diagnose the dog with hip dysplasia, things you can start to work on with your clients. And if they're interested in more advanced things, or if we're down the line, dogs starting to age, get more clinical, our medical management, our pillars aren't quite cutting it anymore, then we have these other options like shockwave therapy, which can provide some pain relief in dogs with osteoarthritis, can be helpful also with tendinopathy, soft tissue issues. It can be performed awake. As you can see, my dog Dodger was a great demonstrator, or under sedation or general anesthesia. I think it's kind of dependent on your patient population, and their demeanor can kind of help determine that. And then of course our joint injections. Typically I use triamcinolone and hyaluronic acid or something like platelet-rich plasma. But of course, like we mentioned in the earlier slide, you can use things like stem cell, you can use synovitin. Really my decision making comes down to the patient's history, how they've responded to previous injections, and the severity of their osteoarthritis, and of course cost. For hips specifically, I do like to try and do these ultrasound guided, since the hip is a bit deeper, to make sure that I'm really where I want to be and getting to the tissue target of interest. But of course you can do it blind, just making sure you aspirate joint fluid back to confirm you're in the joint. And from there, I'll pass it back to Jeff.
Okay, cool. So yeah, for the surgical options here, we'll start off with, what's available if you diagnose these dogs before they have arthritis. In the case of the juvenile pubic symphysiodesis, or JPS, this has to be kind of diagnosed exceedingly early in order to actually be able to do this. But the idea behind the JPS is that we can actually create a premature closure of the pubic symphysis in order to allow, as the pelvis grows, essentially the acetabulum will kind of grow out and down, which will actually improve the femoral head coverage. I guess relative to all the other hip surgeries that we have kind of in our arsenal, I'd probably say it's the most minimally invasive. It just involves a little approach over the pubis. Overall, relatively, safe. It does have to be done in dogs that are between 12 to 20 weeks of age is how they describe it. Getting past 20 weeks of age, there's question whether or not it does quite as much for the hips anymore, so whether or not it's actually worth doing. So this would be something where, maybe a more severe case that comes into you with that kind of classic stance like we showed, where the wide base stance, they're offloading all their weight forward. If you can identify that case early enough and send it our way, or if you're doing these pen hip screenings, this is something where if we hear that you have a JPS case that, the owners are motivated, we can try and get them in, as quickly as we can to try and get this done. But they've certainly shown that this can decrease, like if you improve the hip conformation, it can decrease joint laxity and overall arthritis in the future, and potentially avoiding another big surgery in the future anyways. So these photos here actually show a case. This was about a 15-week-old puppy. This is prior to JPS. So you can see that the acetabulum are a little bit on the shallow side, or they're just kind of a little bit more angled there. And then about 2 years after, and kind of the follow-up, you can see that the femoral head coverage is certainly a lot better than it was, and you don't really see much arthritic changes on that CT there. This is just a photo of a JPS being performed.
Yeah, I can definitely say the dogs that have had a JPS tend to just do better when it's been successful.
Yeah, and unfortunately, it's something that's kind of rarely done, but if you can find the right case for it, it can be a really cool outcome for them. The other prophylactic surgical option out there is the triple and double pelvic osteotomies. I will kind of preface this slide by saying it's pretty much fallen out of favor at this stage. I think it was a lot more popular maybe about 15, 20 plus years ago, back when the total hip options were just not quite as solid. Now that implants for total hips have improved so much, the technique has improved so much. Typically that becomes the go-to for the surgical option. With the TPOs and DPOs, there's still a fair amount of invasiveness to it. You're either making 2 or 3 cuts into the pelvis, you're rotating the acetabulum kind of down to improve the femoral head coverage, and then you're having to plate it back into place. You're doing this in pretty young, rambunctious dogs. You're going to worry about implant failure, infection, all that kind of stuff. And you're usually having to keep those puppies pretty restricted and quiet, very strict for 2-3 months. So not a great option. It certainly has been, for the most part, like something we don't even really recommend at animal surgical, just because we feel like we have just better options in general there. But if you were to consider it, it does have to be done prior to the development of arthritis, so somewhere in that 6 to 12 months range. And any cases where they have really severe laxity or even subluxation are not really good candidates, just because you can only turn out the acetabulum and improve the conformation so much. So, the cases that you're kind of identifying are probably going to be, or at least the easier ones to identify, are the ones that have more severe laxity and subluxation at that young age. And, they may not even really be good candidates for the TPO or DPO anyways. So I guess I wouldn't think too hard about that one. So now kind of going more to the kind of the more common options that we run into. So either the FHO or the total hip replacements. So I mean, ultimately we do consider these procedures as more salvage procedures. We wouldn't really consider surgery really for any hip dysplasia case unless it has really pretty consistent, significant discomforts, some at least level of loss of function. Definitely as they get more to end stage arthritis or it's really affecting the quality of life, then certainly surgery starts making more and more sense. And even if you have a younger dog that does have some more moderate hip dysplasia, if you've tried all the medical management and yet the animals failed, or it's just a very active dog and the owners are not able to get them up to the level of activity they want to with medical management, then yeah, surgery can start being considered. But there are kind of pros and cons for either surgical option, which we'll get into. And it's definitely important to note that deciding for surgery or when to go to surgery for the hips is not really a decision based on radiographs. I've seen plenty of, middle-aged pitties that have horrible looking hips, but, you would never even know about it. So it's going to come down to radiographs to a certain extent, but also a large part just to clinically how they're doing. So that's a very important kind of thing to know. So for the FHO or femoral head osteotomy, so this is something where I'm sure everyone's familiar with this, very classic procedure, been done for a long time. I guess we typically recommend it for more small breed dogs or cats. Those kind of cases tend to do quite well with an FHO. We start recommending a little bit less and less as we get to larger dogs. Certainly medium and larger breed dogs can still do fairly well with an FHO, but they might require a bit more intensive rehab therapy. It just is a little bit more difficult for them to, at least from what I've seen, to adapt to having that level of laxity in the hip joint, given the weight that they have to kind of get around. So when I talk to owners, I do tell them that this leads to a fair to good prognosis in most cases, sometimes pretty excellent, especially in the small breeds and cats. Fairly low risks, generally it's something where the biggest things are going to be, how well can the owners rehab these patients afterwards. So if you have the right owners that can do it at home, that's great, or potentially working with someone like Gina to do kind of the rehab afterwards and they can still do quite well. But yeah, there's some shortcomings. I do kind of warn owners that some of these dogs might have a bit of a mechanical lameness. Like they may not go back to a perfectly normal gait. They will sometimes shift because of the little bit of instability in their hip area. They may just kind of shift their weight a little bit differently, may look a little different as they're walking. But as long as they're comfortable, most owners are going to be quite happy with that. So now kind of to the total hip replacements. So this is by far considered kind of the gold standard when it comes to a surgical option, at least in these kind of older cases or more mature cases. The total hip replacement is a bit more costly, but it does provide, it's kind of the only option that allows them to return back to a pretty high level of function and more of an anatomic repair for the hip. So this is definitely our recommendation for dogs that are more in the medium to large breed. Certainly more active or working dogs, like these total hip replacements are going to give them the most function that we can get them. They do technically have implants for small breed dogs and cats. We just don't find that the risk benefit really makes sense in those cases as much. Just these small breed dogs and cats tend to do so well with the FHO. Why kind of put them through the risk of the potential, what could happen with a total hip replacement? In terms of timing wise, technically these total hip replacements have been described and done in 6-month-old dogs. Here at ASOC, we tend to try and shift it to say like 10 months and older. We just would like to have that femur a little bit more skeletally mature, just so that our implant sizes are going to be kind of more appropriate to when they're actually fully grown. So with these more anatomic repairs, we also have a faster return to function. Rehab therapy can still absolutely be very helpful in these kind of post-op total hip replacements. But they tend to want to use that leg pretty quickly, and they're actually able to build muscle, even if the owners are just motivated to do the rehab at home too. So it's not quite as intensive. For this, there are certainly more risks to it, but ultimately higher rewards with it too. But case selection is very important in these cases. Since the risks we'll touch on here are kind of major, we want to kind of pick the cases that are going to have the least amount of risk to them. So patient demeanor is going to be a big part of that. So if you have an active dog, that's fine. But if the dog is crazy, bouncing all over the place, and owners can't keep the dog restricted at all, then probably not a great total hip candidate. Same thing with maybe super aggressive dogs. If we can't really touch the animal, it's going to be hard to really treat them as thoroughly as we kind of need to for a total hip replacement. So that might also take them out of the running. We also do kind of systemic workups. That's something we want to rule out any kind of underlying reason why they'd be at an increased risk for infection, or have any kind of decreased ability to fight off infection, or any even systemic illness that might affect bone healing, because this surgery does revolve around kind of bone integration. Owner compliance is certainly a very important aspect to a lot of our surgeries, but even kind of more so maybe for the total hip replacements. So to go through some of the complications, I'll preface this slide by saying that a lot of these complications are also very, very rare. Certainly they can happen, and when they do happen, they're kind of a big deal. So we go through all this stuff when we talk to owners about these types of cases. Of these big complications here, I'd probably say luxation is the biggest major complication that we may see. That even then it happens pretty rarely, but when it does occur, it's usually going to happen because they're a bit overly active in the first several weeks after surgery, and they have a slip and fall. So this radiograph here is actually, I believe this is like a couple years ago. This is like a 1-year-old, pretty crazy golden retriever. Owners had a lot of trouble just keeping the dog restricted in any kind of way, and the dog a couple weeks after surgery ended up getting kind of a caudo-ventral luxation there. And those luxations are kind of classic for a dog that falls and splays its legs out. So although I don't think the owners witnessed it, that probably be what happens. So we were able to revise this by reducing the hip back into place. I believe we just changed out the femoral head implant a little bit just to tighten up the hip a little bit more, and hopefully make it harder for the dog to luxate it out. So yeah, that dog went on and did well, but that is one potential concern of this, since there's not actually like any kind of prosthetic ligament that's attaching the femoral head back into the cup. It's purely based on the stability provided by the implants, creating tension at the joint, and then the muscles, joint caps, all that kind of stuff, holding that tension for them. Infection, another potential risk. Also very low complication rate. I'd probably say well less than a 1 to 2% risk for infection here, at least from the caseload we've seen. The reason why we mentioned to all owners is because if there was an infection, just the nature of orthopedic implants is that infection will probably not be cleared just with antibiotics alone, and we'll probably have to remove the implant. It will probably leave that animal with an FHO ultimately. So not the outcome we were hoping for, but still, I guess, not the end of the world, but certainly we are exceedingly cautious about the potential for infections with these total hip replacements. Femur fractures, extremely rare. I had to find this photo online. And it's technically possible. I mean, as we're placing these implants in, it's certainly possible to have a fissure or crack. But most of the time, if there is going to be an actual fracture, it's typically from overactivity in the first several weeks and subsidence of the implant, which is going to create a fissure. So as long as the owners are able to keep their pets fairly restricted, chances for femur fractures is very, very low. Sciatic nerve weakness, a possibility. It can happen. It's usually going to be temporary. It's just from the nature of having to retract back the tissues in order to get down to the hip. And it usually goes away within a week or two, typically not a big deal. Implant loosening, very, very rare, especially now with the improved kind of implants that we have. So in the left photo here, this is actually a cemented, kind of the older style hip, where the stems are actually cemented into the femur shaft. And you had more issues with, as dogs age, they would have more loosening of the kind of cement implant interface. Nowadays with the newer implants, we have these kind of bone integration implants where essentially the bone actually grows into the implants over time. So with that, we just see less issues long term. So just to show you that there are good outcomes with total hip replacements. This is actually one of Dr. Johnson's dogs. The black and white one here had bilateral stage total hip replacements. I believe she was rescued with pretty severe hip dysplasia, and he did those hip replacements. And now Frankie here is living her best life. Okay, so now back to kind of post-op and how to kind of deal with some of these patients.
Yeah, so in the immediate phase, we definitely our number one goal is pain management. So you won't see a ton of therapeutic exercise, you know, if anything, you'll see things kind of similarly to what you see in this picture, where we're just purely encouraging some weight bearing throughout that leg. But again, really our goal is pain management. So things like cold compressing, stretching the surrounding muscles, particularly those cranial hip flexors that tend to get nice and tight. And then the use of obviously something like a help them up harness, just to keep them from slipping and sliding while they're still kind of figuring everything out. As we get further and further out, then we can start to really work on the strengthening. This is the time that I feel like the dogs really love. They love their spa therapeutics immediately post-op because it feels nice, but this is the most fun for your clients and your patients because they get to be more active. So again, this is when I would start to bring in things like my underwater treadmill therapy is, like I mentioned, great for hip dogs, both medically managed and post-operatively, using things like resistance bands. Have Boston here who is doing a figure 8 around cones, and Letty doing some backwards walking. A lot of times in these hip dogs, we'll see atrophy and weakness of the hamstring and gluteal muscles. So doing things like a sit to stand, which is basically illustrated here in the bottom middle image. It's like a doggy squat. And then of course, encouraging hip extension and flexibility. But yeah, lots of different things do that owners can do at home as well. So thank you so much for taking during your busy day to listen to us talk about hip dysplasia. And so we'll take this time to answer any questions. Okay. So we'll pull up our Q&A. Opinion of the Assisi loop for osteoarthritis pain. Yeah, so the Assisi loop is what we consider a PEMF device, or pulse electromagnetic field. So there is some evidence that it can help. Unfortunately, like I'll say, scientific research, it makes it really hard to evaluate those things. I know the Assisi loops are really common, and PEMF beds, PEMF blankets on the eastern side. So it is something that we use pretty commonly. Both I use them at Colorado State, and we use them here at Sound. And it's very low risk. Big important things you obviously want to be mindful of is things like pacemakers on your patients, or any other things like that. Osteoarthritis. So like I mentioned, it's actually a lot higher than what is conventionally thought of. So body weight, using kind of that classic RER equation, so the ideal body weight in kilograms to the 0.75 and multiply that by 310. That should give you your milligrams of EPA and DHA. And again, I emphasize that it's the EPA and DHA. And again, you can see products that have a little more EPA than DHA. Doesn't matter. We're looking for that combined total dose. Another easy way to calculate it is basically taking your RER, multiplying that by 4.4. That'll give you this answer. And then
All the questions are for you.
I
Get that.
feel very welcome. Do I recommend Dysplasia Advanced, Cosequin, or Antinol? We carry Dysplasia Advanced, but wondering if we should just be recommending an omega-3 fatty acid supplement. So obviously these more advanced versions like Dysplasia Advanced do have some additional things like ASUs, green-lipped mussel, things like that in them, which have some evidence behind them. Green-lipped mussel does sort of fall into that omega-3 fatty acid. But if my honest opinion and based on the research, like I mentioned, don't really tend to push Dasaquin or Cosequin for owners, especially if they're not already on it. I tend to focus more on the omega-3 fatty acids. I think, again, the really important thing is, like the name implies, most of these things are carried in an oil, which is a high fat, so high calories. So in my dogs that are overweight and we're trying to work on weight loss, I do tell owners to hold off on giving it until we've reached a more ideal weight, because why fight against ourselves when, again, weight loss by and far is probably one of the best things we can do. Great question though. And then any opinions of Adapon sub-Q, easier for administration at home? Yeah, I absolutely always tell owners to give it sub-Q. I don't want them giving IM injections at home, and their dogs probably don't either. We don't have any evidence, even though it's labeled for IM injection, we don't have any evidence that it's less effective given sub-Q. So I pretty much always train owners to do it sub-Q. All right, I think that's all of the questions that we have and all of our time as well.
I do have one question in the chat.
Oh,
Sure.
When do you switch from PRN NSAIDs to daily? I've also heard giving it before heavier exercise is worse than giving it after. Can you explain?
So when do I switch? A lot of times it's based on the dog. So usually when they come to me, they're still pretty painful and may still be in an acute inflammatory phase. Whether they're, again, the young dog or the older dog, we can kind of kick in that re-inflammatory phase. So I'll usually do anti-inflammatories for 2 weeks, sometimes a little bit less, sometimes a little bit more, just while I kind of work on other things, again, physical therapy, exercise, to help them feel better. And then again, really my goal is to, especially with hip dogs, try and get them to the lowest efficacies on an as needed or PRN basis. As the dog starts to age and we start to see them slow down, it may be something where I see them needing the anti-inflammatories more consistently. So again, not a great answer, but it's really dog dependent and how they're doing clinically. For the other part of your question, in terms of giving it before versus giving it after, I actually will tell owners to do both. So a lot of times I will tell them, hey, if you know that your dog is gonna go camping with you or go on a particularly long hike that they're not used to, I'll usually say, hey, give it to them before and then give it to them afterwards to just kind of mitigate some of that inflammation and pain that we know is going to happen secondary to it. But great question. What's Icon? Is it worthwhile? I'm actually not familiar with Icon. I don't know if you are. I would have to do some research to figure out what it is and get back to you.
Well, thank you very much again. You know, if you do have weird or interesting cases, you're not quite sure what to do with them, also feel free to, you know, email us or send us your cases too. I know a lot of radiologists these days have been saying, like, you know, go to do an orthopedic consult. You know, you can also call and email us too. You know, we're happy to answer your questions through those modalities in case you're not sure exactly where to send your client yet. All right. But I guess with that, we'll go ahead and wrap it up and have a good day, everybody.
Thanks so much.
Done.